Hello, and thank you so much for joining us for this video series titled Teaching and Learning Evidence-Based Relationships, Interviews with the Experts. This project is brought to you by the Society for the Advancement of Psychotherapy of the APA Division 29, and it is a companion project to the third edition of the book, Psychotherapy Relationships That Work. The overall goal of the project is to translate relationship research to teaching and learning from the classroom context to clinical supervision. My name is Dr. Raina Markin, and today we are very fortunate to be joined by Dr. Michael Constantino, Professor and Graduate Training Director at the University of Massachusetts Amherst, and who happens to also be the current president of Division 29. The topic of today's discussion is how to translate research on patients' positive outcome expectations to teaching and training. Hi, Mike. Thank you so much for joining us today.
Hello. Thanks for having me.
Absolutely.
Glad to be here.
So to start off, I just wanted to ask you to start by defining the psychotherapy relationship element, positive outcome expectations that you reviewed for your chapter in the new edition of Psychotherapy Relationships That Work.
Sure. Yeah, happy to do that. So our chapter focused, as you mentioned, on patients' outcome expectation. I have to say I will probably slip at some point during this interview and just say OE. But when I say that, I mean expectation, right? Which is essentially patients' prognostic belief about sort of what the mental health consequences would be if they were to participate or go through a given treatment. And I think we often think of, as clinicians, wanting outcome expectation to be positive or high. And in some ways that would precipitate Jerome Frank's notion of a person becoming remoralized in some way, or gaining hope that there may be a path to personal improvement. And so, you know, to us, we've always struggled a little bit in that outcome expectation is it's squarely a patient variable, which sort of means it fits a little bit less snugly into the book's general characterization of relationship elements, and this volume in particular talks about therapist contributions. That said, you know, if you know that expectancies can be powerful, then as a therapist you can try to influence them, and you can even use the relationship to try and enhance or shape a person's optimism. So, you know, in that sense, despite being squarely a patient variable or trait or characteristic, you can see how OE is connected to the provider, it is connected to the patient-therapist dyad. And of course, as the relationship unfolds, it might even be the case that the relationship could cause some waning in one's outcome expectation. So, you know, clearly it's connected to the provider and to the relationship.
Right. No, I would think that it's partly an individual level variable and partly a dyadic variable, that it's influenced by both the patient as a person and their general tendency and the relationship.
Absolutely. I think they all are in the mix. And as, you know, John has directed us as authors of this really important volume, you know, we're also trying to think of ways in which the evidence tells us we can affect patient level characteristics for the good.
So can you summarize the findings in your recent meta-analysis?
I can.
Good question.
It is still on the forefront of our mind as we just wrapped all this stuff up. But as you know, in the latest edition, we actually updated a previous version of our meta-analysis of the patient OE treatment outcome correlation. Importantly, I think just to set a little context, we are very aware that one's outcome expectation can change across treatment. And as we just discussed, it could be shaped by things like the therapist's actions or patients' appraisals or reappraisals of what's going on in treatment. But for the meta-analysis, in part driven by the bulk of the research, we centered on outcome expectations that are formed either before treatment starts, so at a true baseline, or just after having some sort of minimal exposure to the therapist or the treatment. So our test was really sort of a true long-range forecast of a person's ideas about treatment response. And so in our initial meta-analysis, focusing on clinical samples only, we found a small but significant association between patients having more positive outcome expectation and more adaptive post-treatment outcomes. And it explained about 1.5% of the outcome variance. In our update, just completed update, with almost double the number of samples, which I think speaks to the amount that this construct people have taken a renewed interest in this construct. The effect also doubled. So outcome expectation now explains about 3% of the outcome variance. So to us, we think that this result sort of further legitimizes the scientific credibility, so to speak, of what were formerly, I think, poorly named non-specific factors like patient outcome expectation, which of course is a central goal of the entire volume and book of John's.
And did you find any sort of interesting moderators in the meta-analysis? Did you look at that as well?
We did look at moderators, yeah. It's a great question, and we actually didn't know moderators emerged in the first meta-analysis, but with more samples and presumably more power, we actually had 3 that showed up in the latest. And so basically, the outcome expectancy treatment outcome link was stronger for younger patients when researchers used an established measure of OE, and when therapists were using treatment manuals, or when their treatment was at least partly guided by treatment manuals.
Interesting. So given your findings, how do you train graduate students to attend or to be competent in OE in sessions with clients?
Yeah, it sounds like it should be such an easy, straightforward answer. Of course, it's not.
Yeah.
So here's what I attempt to do. First and foremost, I train graduate students to attend to far more than patients' diagnoses when they're conceptualizing cases from the outset. And so I really urge them not only to take non-diagnostic characteristics into account, like an outcome expectancy, but also to consider treatment planning sort of a constructive experience that relies on the many different things that you learn about a patient, and what experiences that you have when interacting with them or sitting across from them. And so to these ends, I think, one's outcome expectation is just one small piece of a complex puzzle, explaining one small percentage of outcome variance, but importantly and reliably so. And so I think I really just try to take that relevant piece into account. And so here are just a few things that I think I do specifically to that end. First, I have students review papers or syntheses of the literature on outcome expectancy. And I think what this does is it really serves to raise their consciousness on what makes addressing an outcome belief evidence-based, because many students don't necessarily think that broadly about what evidence-based practice is when they come into a program, a training program. They often think of it in terms of just sort of a packaged treatment. And of course, outcome expectancies are pan-diagnostic, they're pan-theoretical, they're just relevant because patients come in with them. And so I try to have them review some of the literature so they see why this matters for evidence-based practice. I try to teach students to assess outcome expectancies regularly. That can be verbally by just talking to your patient, but it could also be through a brief measure, like some of the ones we wrote about in the chapter. And I think importantly, to the extent that direct assessment like those two methods might produce in some ways guarded responses from patients, I also try to help students look for, I guess you could call them proxy markers of lowered hope or optimism for treatment response. And those things there could be many of them, but it could be resisting the therapist's direction, it could be disparaging one's own progress, missing sessions, it could be a lot of things, but certainly there are proxy behaviors that could suggest that one is losing optimism or hope in the work that you're doing. So then in response to those markers, whether they're direct or indirect, I first train students to just stop whatever it is that they're doing.
Uh-huh.
What I refer to as sort of a marker-driven departure from any kind of sort of a priori treatment plan. Because a lowered OE, especially if it was lower relative to a first assessment, really does suggest there's something about what you're doing or the way you're doing it or how the relationship is unfolding that isn't quite working. It's not believable or as credible or as hope-inspiring as maybe the patient once believed. So the first thing is to just sort of pull back and stop. And then ideally, I try to teach students what some marker-driven responsive OE enhancing or OE persuading strategies can be based on the existing literature. And so, we talk about several of these specific chapters in the therapeutic practices section of our chapter, which we hope people will read. But once we get into what some of these interventions are, I usually find that using some sort of discuss it, see it, and try it method works rather well.
Great. So are there any readings or videos that you assign to your students, maybe inside or outside of classroom or supervision, to help with the training process?
Yeah, I have some favorites, and this is by no means an exhaustive list, but first and foremost, I really urge students to read Jerome Frank, Persuasion and Healing. I mean, I think it's timeless, and I think it can be still seen as so highly relevant to many things we do in therapy today, and certainly outcome expectancy is one of them. There's a narrative review that was published in 2006 by Roger Greenberg, who is really a pioneer of expectancy research, and incidentally, he was a mentor of mine on internship who sort of first tuned me into this construct. And so that was so he wrote a review that I think really sort of captures a lot of the early work and then some of the work up through 2006. I also wrote a chapter with Henny Westra, for which we outlined an expectancy-based approach to facilitating patient corrective experiences.
Yeah.
And so I think that model really helps trainees think about therapy at more of a trans-theoretical level of social influence. And speaking of social influence, I will often also assign some readings by Stanley Strong, who has this social influence theory, which I think has high relevance for how we can sort of use the therapeutic position or relationship to affect people's belief systems. So those readings sort of set the theoretical foundation for me. To get more practical, and when we're rolling up our sleeves, we actually elaborated on the therapeutic practices section of our last version of this chapter, and we published it in the form of a practice review in Division 29's journal Psychotherapy. And so that one is much more sort of based on the evidence, what can clinicians actually do to affect. And so I still actually use that one quite a bit when I'm doing a clinical team or doing direct supervision and covering a module focused on OE. Yeah,
those all sound very important and very kind of bridging theory, research, and practice.
Yeah, exactly. I think that's what I'm trying to achieve.
And do you use any measures or credibility checks in your teaching of OE, either to inform your teaching or to encourage students to use valid measures of the relationships in their own clinical practice?
Yeah, I mean, the latter for sure. As I talked about, seeing OE as a patient level variable, I'm mostly encouraging trainees to use brief validated OE measures in their routine clinical practice. In fact, in our department's training clinic, we actually started inserting the credibility expectancy questionnaire as part of our routine core battery, among other measures. And so it's something that our students are sort of constantly thinking about, in that all of their patients through their training will be completing these measures. And of course, different supervisors will do different things with those data, but certainly patients are sort of reporting on their OEs across time. I mean, I think at the therapist level, you can certainly measure how much a therapist learns and adheres to certain types of strategies, including OE strategies. But I think it's far more likely that personalization to any given patient is probably the key to assessing, addressing, and influencing patients' beliefs. So I tend not to do adherence checks or credibility checks, and that's in sort of a traditional research sense. But rather, I'm trying to give sort of case-by-case feedback and supervision, as opposed to thinking about it as sort of a competency that you can sort of achieve, maintain, and then have evaluated from somebody else. I think personalization is far more likely to be the means to affecting a given patient's belief system at a given moment in a given course of therapy. Yeah, in fact, I've actually tried to move in sort of a recent development, tried to really move away from this idea of sort of competency-based trainings or teachings, because I do think they imply that therapy skills are things that can be sort of acquired, mastered, and then sort of applied consistently across therapists and patients in a way that sort of uniformly facilitates good outcome. And I think, as you know, the research really challenges that notion. And I think the research really does tend to support more of the idea of tailoring or responsiveness or personalization.
And even I would imagine someone's competence to facilitate positive outcome expectations in a patient is not just a trait-like variable, that it very much can be influenced by the character of the patient, their own relationship, and what's other factors are going on in that relationship, or even the therapist's own personal life at that moment.
Absolutely. That's very well said. Yeah.
So what are the most common challenges that you encounter when training students to attend to outcome expectations? And secondly, how do you suggest remedying those problems?
Right. Yeah, they exist for sure. I guess I can comment on a few. I think an obvious one is, what does a student do, or how do they react as a clinician if a patient conveys that their outcome expectancy is low, or they become more pessimistic, they've lost hope, they become demoralized again. I think that can be a situation where a clinician, maybe especially a novice clinician, can sort of take a hit to their own self-esteem or their own sense of competence. And I think with trainees being pulled to enhance their self-presentation and to avoid negative evaluation, especially in supervision, they may have a difficult time fully attuning to a patient's experience and somehow divorcing it from their own, right? That this might mean something for the patient. It doesn't necessarily have to mean something for your own general competence as a clinician. But if you're worried about that and you're attending more to your own need to feel better in that sense, you may be missing some of the core clinical material that is actually causing the disrupted OE. And I really think that could manifest problematically in many ways, but one might be where the therapist sort of doubles his or her efforts to tout their own effectiveness or the effectiveness of a given treatment, which may only serve to reinforce the patient's pessimism, because in some way that was probably not working, which is why their OE lowered in the first place. So the key, which is also the big challenge, is to help trainees realize that it's the patient's belief in what will help them that in many ways is the most important thing, not your own belief in why this treatment should work or why I should always be helpful. And again, this harkens back to Frank and the idea of finding a good sort of myth ritual match that a patient finds credible. But you have, clinicians have to give up a fair amount of their own. They have to become more humble, and I think that's a hard thing to sort of teach or help early trainees tolerate. But I really like Jesse Owen's work on multicultural orientation, because he talks about helping people learn to tolerate and attend more of what they don't know as opposed to what they do know, this idea of competence. So I think the idea of humility over competence is something I'm trying to sort of lace throughout most of my clinical trainings. But it's a challenge. It's a challenge to tell somebody to come into a program where these are very high achieving individuals,
right,
and say, you're not going to know, and you have to tolerate that and be humble. And oh, by the way, not knowing and being humble and being empathic and attending to your patient, that probably is expertise.
Right.
It's a very different way of defining expertise than they're used to.
Yeah. It goes against how they've learned and been successful in school for so long.
Exactly. And I think one other thing that you're trying to work with therapists to avoid a pull is to not outpace a given patient's outcome expectancies at any given time, by conveying more optimism in a treatment than a patient is willing to accept. I think sometimes you have to lead by being a step behind, and you don't want to rush out of the gate and try to sound too optimistic, too Pollyanna-ish, where a patient just isn't ready to believe that and therefore finds you and the treatment as lacking credibility. And so that's a pull that you also have to help students counter.
And the challenge, as I hear it, is a lack of personalization, right? Like learning not to personalize when patients don't have confidence in the treatment, and humility in accepting that it might be something you're doing or something that's going on. But I think also helping students understand that it might just be diagnostic of what the patient has experienced before in relationships, that they don't have experiences of being helped. So why would they expect this to be different?
Why would they expect this? In fact, they would expect more of a recapitulation of people in their lives not believing in them or not being optimistic about their future. And in some ways, you may have to meet somebody there where you can affect change, because to affect change, and this goes back to strong social influence theory, you have to become an important other who people see as credible and worthy of internalizing their influence. And that takes time in therapy. And so part of the challenge there is, over that time, you may feel ineffective. Yeah. But everything that you said is true. It's like, but that might require some meta-communication about what's going on between us. It might require taking some responsibility for that. And in some ways, that's what psychotherapy is. That personalized movement toward what the patient needs, but also being able to sort of not personalize what it must mean for you as a clinician across the board.
Yeah.
So a compartmentalization in some ways. Yeah. Not easy to teach.
No. Not easy to teach, not easy to tolerate.
Not easy to do. Yes, exactly.
What about for other psychotherapy trainers? I mean, what readings or resources or websites do you suggest, if any?
Yeah, I mean, I think the reading list I mentioned earlier is pretty much where I'd go. But I would say that, just to sort of plug something, I'm actually working with Bruce Wampold and colleagues to develop a training module for how to effectively address patient OEs, which will actually involve using video vignettes of sort of markers of actual patients showing lowered OE. Clinicians can then view those, record their clinical response, give themselves feedback on how it went when they rewatch the video, get supervisor feedback on how it went, and then do deliberative practice to sort of keep going over and over in that vignette until you do something that seems clinically just right or well-timed. And so this is a really personally exciting development to be involved in this. Because I think it can really represent training in sort of a new key. So sort of moving away from empirically supported treatment manuals and really more toward this idea of evidence-based responsiveness on common clinical occurrences. And ideally, once this is done, trainers can use these to sort of build their own ongoing lifelong learning, but then also turn around and use them in their clinical pedagogy with trainees and students. And so that should be coming soon, but it's worth mentioning because the timing is really perfect with having just completed this this chapter and being forced to think about training implications.
No, that sounds great. So what do you think are the most important lessons for psychotherapy instructors and supervisors to take away from your research?
Well, let's see. Probably that although the research on what can causally affect patients to change their OEs for the better is still relatively preliminary. the research that we did, the meta-analysis that we did is sort of decidedly a correlation. In fact, we tried to do a meta-analysis on experimental studies with clinical samples, and there just weren't any that existed.
Right.
So a lot of what we're learning in terms of how to cause a patient to have an increased OE is still very preliminary and often from analog samples. That being said, there are findings, and they can guide what you do. And so I really do think that the biggest lesson is that this is a literature that exists, and I think you should heed it as a trainer and as a clinician. It's also a literature that's growing, and so it will change. So I wouldn't get too rigid about it, and I would keep on the lookout for new things that we're learning. And I would just say that somehow I would hope that we as a field can sort of change this, what I think is an unfortunate disconnect. And we've done some surveys in this regard where you talk to people running training programs or involved in training programs, and they almost all say, focusing on common clinical factors is really, really important. And then if you ask them how do they make it part of their training curriculum, they almost all say we really don't. There's no space, or we just can't, or supervisors would be resistant. And so I really, if there's a way to take what's being compiled in this book and really kind of get it to change the culture of how we think about training, I think that's an outcome of a lesson that I hope to see down the road.
Yeah, that's right.
And maybe that, like in the maybe not so distant future, the days of our trainings being these long form clinical trainings focused on how to deliver a brand name treatment package with high fidelity, that those will somewhat go by the wayside, and we'll get into these more efficient evidence-based responsiveness modules that we can practice and that we can keep shifting as the literature shifts. And I think that's far more likely where we will ultimately end up in terms of training and continuing education, but we're certainly not there yet.
Yeah, thank you. So what do you believe are the next steps? So where do you think we need to go in terms of evidence informing teaching and training? And you kind of just maybe answered this, but I don't know.
Yeah, well, right. Well, I'll talk about one more thing. I did speak to that a little bit in the last response. I apologize, but these things, they're such good questions that they all link. So my thinking, the one thing that I want to point out is the idea that I think we have to hone in on understanding more about between therapist effects. And why is it that some therapists are reliably more effective than other therapists, both in terms of producing global outcomes, but also in terms of producing specific outcomes. And one of the things that we're just starting to learn is that if you're going to find out what are some things that determine or predict those between therapist effects on outcomes, you have to have variables where there are between therapists differences on those predictors. And as it turns out, there are some therapists who are better than others across their caseload at facilitating positive OE in their patients. And so if now that we know that, that can become a predictor of between therapist effects on outcomes, and then we can start to work backwards. What is it that those therapists do relative to others that makes their patients have more optimism? And if we can find those things, then those are the things that I think those are the things that should become the centerpieces of our training, because those are actual things about the therapist and about presumably things that can be malleable. And that's what we're trying to do in training, right? We're mostly trying to manipulate the therapist to be helpful. And so I think that's hopefully the next time the fourth volume or edition of this book comes, there'll be a lot more research on determinants of between therapist effects, including the facilitation of optimistic OE.
It again gets back to this point I think that you're making earlier, that a patient's outcome expectation, there might be a trait level to it, but that it's also dependent on therapist factors, relationship factors, and we can teach our students and trainees to cultivate those aspects they have control over, so to speak.
Yeah, right. Yes, to cultivate and to understand that what sort of, it's like probably two different levels, right? At the therapist level, there are probably some things that can be done over and over again with a lot of different patients that would cultivate and be useful. but there's also going to be the patient level that says what people see as useful is probably going to differ depending on so many things, diagnoses, culture, identities, many different things that then come into interaction with the therapist and his or her cultural identities and his or her, you know, interpersonal histories, et cetera, et cetera. It's complex, of course.
Well, this has been incredibly helpful and interesting. Thank you so much for joining us and sharing all this information. I think instructors, supervisors, students will all really benefit from it.
Well, thank you for having me and for starting this initiative. I think this is really great, and I'm excited for Division 29 members to be able to view these videos.
Great, thank you.
Thanks.